Morning, everyone.
Good morning, everyone. Hopefully you can hear me. This is Chicky Flowers over in Salem. We are currently at 8:58. We'll officially get started at 9:05. Thanks for kicking us off, Director Stolfi.
Pleasure, and I can hear you very well. Thanks.
Hey, good morning. This is Lindsay, just doing an audio check. Can anybody hear me? If you could let me know in the chat box. Oh, I see. Okay, thanks. Thanks for the thumbs up, everybody.
Well, good morning, everybody. This is Craig Anderson, Committee Chair. I wanted to welcome everybody to the July 2023 Health Insurance Marketplace Advisory Committee meeting. And you should have all received last night the packet for today's meeting. So you can follow along with that, but you also will go through that online as well. So please note in the agenda that we put an asterisk next to all the items that relate to the committee's work plan as well. And so just looking through the agenda, not surprisingly, we'll do a lot of discussion about the unwinding process and the bridge program. Believe it or not, we're 3 months into this process, so we'll get some updates on that. And then we'll have a wrap up of the legislative session with some news on potentially a state-based exchange. So that'll be good. So first order of business, before we get into the guidelines, I would like to ask Chicky if she'd take the roll.
Sounds good. Thank you so much. If I call you, when I call your name, if you can please identify that you are here by in person, on the phone or by video, that would be fantastic, please. Chair Craig Anderson.
Here in person.
Gladys Batwell.
Via Zoom, or sorry, online.
Thank you. Ron Gallinat.
Virtual here.
Thank you. Maribeth Guarino.
Here by video.
Paul Harmon.
Here by video.
Vice Chair Lindsay Hopper.
Good morning. Present by Teams video.
Ines Kemper.
Also here online.
Shannon Lee.
She said she was not going to be able to attend because she was not feeling well.
Okay. Thank you. Jody Moore. Danielle Nichols. Polly Sorensen.
Morning, everyone. I'm here by video.
Thank you. Director Stolfi.
Morning. I'm here via video.
Sakinai.
Good morning. Yes, here audio and video.
Drew Tarab.
Good morning. Here audio only.
Thank you. Nashoba Temperley.
Here by video.
Thank you very much. Good morning, committee members. We have official quorum, and you have the HIMAC staff here also in the room. You have Victor Garcia, Don Shaw, and Chicky Flowers, and Nina Rempel is also in the room to present. We also have our various presenters online and ready to present at their given time. So back to you.
Thank you. All right, next we'd like to go through the meeting protocols, and just to remind everybody, the Marketplace and HIMAC Committee is a safe and inclusive meeting for all attendees, and we have a number of perspectives, and that's by design. So please offer your opinions as you feel fit. And again, if you have any questions, don't hesitate to interrupt and ask those. And next slide. Please be on camera as much as you are comfortable, and mute your speaker when you're not talking. And if you have a question, please raise your hand virtually or put them in the chat. And there is an option available if you need accessibility for captions. So with that, the first order of business is that we need to approve the minutes from our last meeting, and Don sent them a draft of those out on June 21st to everybody, so people should have had a chance to look at those. Is there any discussion before we move to the approval of the minutes? Okay, hearing none, I look to somebody to have a motion for approval.
Ron Gallinat, I'll move approval of the minutes.
Thank you, Ron. Do I have a second?
Drew Tarab, I'll second.
Thank you, Drew. All right, so all of those in favor, you could just say aye audibly or raise your hand virtually.
Aye.
So, all in
Aye.
favor?
Aye.
Aye. Okay,
Aye.
thank you.
Aye.
Aye.
Great. Anyone opposed? I don't hear anyone. All right. Thank you for that. So for our first agenda item, we will be hearing from Stephanie Keenan. She'll give us a federal policy update this morning. Last time we heard from Stephanie, we were trying to avert a debt ceiling crisis. So I think that's been averted, and we'll see what she has to tell us this morning. I think I saw Stephanie online, so.
Stephanie, I think we see you, but you might be on mute.
There I am. You would think by now I would know to unmute myself. So good morning. Yes, we averted a debt ceiling crisis, but we still have an appropriations problem. So let me start by giving you kind of the lay of the land. The Congress is in until the end of July. Then both the House and Senate leave for August recess. When they come back, they should be worrying about appropriations because the end of the fiscal year is going to be September 30th, as it is every year. However, the debt ceiling agreement had some interesting things in it that impact the appropriations process. And I'm just going to sort of lay it out for you because it impacts how Congress is going to be able to move or not move in the fall. In the debt ceiling deal, to avert having the government default, Speaker McCarthy and the White House worked out legislation that capped some spending, and it requires that appropriation bills be passed by December 31st, or a 1% across the board hit happens to all programs. This was not met well by the conservative caucus in the House, who, after passage, held up the House for several days on procedural votes. When you bring legislation to the floor in the House, you have to vote on a rule by which the legislation will be considered. They wouldn't vote for any rule, and that hadn't happened in decades. So Speaker McCarthy had to send the House home and figure out what to do. And what he figured out was, in the House appropriations process, the appropriators are very specifically cutting the levels that they are appropriating at. Some have gone back to 2019 levels. And that is not what the spending caps say they will be in the the debt ceiling agreement. Over in the Senate, they are appropriating at the cap level that is in the debt ceiling agreement. This means that we're very far apart in the House and Senate in terms of the spending levels. Not only that, when the I keep saying deficit, when the debt ceiling agreement was passed in the Senate, the two leaders of both parties said, oh, gee, there's nothing in here that says we can't do emergency supplemental appropriations. If there's a disaster or an emergency of some kind, yeah, we can pass more money. Speaker McCarthy said, no, I don't agree with you. Well, in the Senate, they have worked out a labor HHS appropriations bill, and in it, they put $14 billion of emergency supplemental spending. So not only is it at the cap agreed to in the debt ceiling agreement, but they added $14 billion to it. So the sides are going to be very far apart. What we expect to have happen is when they come back in September, at some point they'll pass a continuing resolution. They'll kick the process down to December, and then in December, the crunch time will come and everybody will be worrying about a government shutdown. I don't think the government will shut down, but I think it's going to be very, very difficult for the two sides to come together to get the appropriations finally done. And they could kick it down the can again and try to do something else. But if they kick it down the road, a 1% reduction will happen anyway. This is obviously exhausting and will take up a lot of time. And some people say the sausage making isn't going to be pretty, but that's a lot of the political capital and upheaval is going to be happening then. But let me talk about some other things that are going on. 2 weeks ago, the administration proposed reversing a Trump-era regulation related to short-term health plan coverage. HHS, the Treasury, and Department of Labor were all involved in putting out these proposed rules. And the plans under the proposed rule could last 3 months with 1 month of renewal. There's also some requirements for additional consumer information so that people know what they're actually buying. Consumers currently enrolled in short-term plans could be grandfathered in under the old rules. This all sounds great and wonderful, and people are happy who want to do away with short-term plans because this is sort of the compromise that everybody goes to. Unfortunately, some people don't think it goes far enough. They wanted limits on the sale of short-term plans during the open enrollment period and a few other restrictions that are not in the rule. As I said, this is a proposed rule. They're trying to finalize it now. So one thing to keep watch on. I don't think they're going to make many changes from what I hear. I do know that people are pushing for more consumer restrictions. I just don't think that's going to happen. The second thing that they announced at the same time they announced that proposed rule is that the administration is rolling out guidance intended to close a couple of loopholes in the No Surprise Billing Act. One is that the HHS was concerned that health insurers are relying on certain kinds of loopholes, such as contracting with a hospital but claiming it isn't technically in the network. The guidance said that that is not allowed under federal law and that healthcare services provided by these providers are either in or they're out. You can't have them in your network and then say they're not. And a plan in a hospital has to make people, the patient, aware of if they're going to be additional fees. The last part of this announcement was that the HHS, Treasury, and the Consumer Financial Protection Bureau have asked for more information from experts, consumers, et cetera, on the use of medical credit cards. And these cards usually have high interest rates. Some of them are actually sold in waiting rooms, apparently. And they're looking at trying to how to restrict those because they feel that these are not following any of the financial regulatory rules that are in place. All of this is the administration trying to say, we're looking out for you and we're trying to find ways to lower costs. And speaking of lower costs, PBMs. I've mentioned this before. There are multiple bills and multiple committees that have considered legislation to reform pharmacy benefit managers. In fact, there's some negotiations going on today in the Senate. There's bipartisan support, and the framework is usually something about transparency and also delinking PBM's revenues from the price of a drug because they believe this incentivizes the PBMs to have higher drug prices. Many of these bills approach them from different ways depending on the committee jurisdiction. In fact, the Senate Finance Committee next week is having a markup on PBM legislation as well. All this means that at some point in the fall, we'll probably see some things packaged up in the House and packaged up in the Senate, and some pharmacy benefit legislation actually would get through. It's really kind of interesting to watch this process because no one's really opposing anything except pharmacy benefit managers who are concerned that the secret to their secret sauce is going to come out of the process and they won't be able to do what they do. But it's very rare to have a lot of segments of the healthcare sector get together and say, yes, do this. That's actually happening on this. The last thing I want to mention is that there's a lot of discussion about transparency in healthcare coming from both the administration and Congress. The administration is trying to extend the kinds of regulations that they have in place for hospitals so that hospitals have to say what service costs, trying to actually make what they're required to do now better so people can actually find it and have a better understanding of the information. And we're expecting that that will be discussed a lot in the fall as well. So with that, I'll stop and see if you have any questions.
Great, thank you, Stephanie. Are there any questions for Stephanie this morning?
The quiet group.
Well, I have one while people think about it, and it has to do with the appropriations process, which you described. And I won't say I followed that in great detail, except that we might face some cuts potentially. Is there anything that we need to be concerned about that would affect, I don't know, the individual market or what we work on?
I mean, any federal funding may get a little bit of a nip, or I think one of the big worries that some of the advocates have is what happens to the funding for navigators and that kind of thing. Most people are expecting that within the health sector, most programs will take a little bit of a hit. Depends on, where it is, of how much, but there will be some kind of hit probably for a variety of funding mechanisms that you may unconsciously rely on, or you do consciously rely on.
Okay, that makes sense. Thank you. Looks like Andrew has a question or comment.
Yeah, thanks. Just a comment to share on the short-term proposed rule, just so everyone knows. A few years ago, when the prior administration made the rule change, Oregon put into place a state law capping short-term plans at 3 months. So basically copying the Obama administration's then short-term rule. So that's still in place. Everything DCBS, we're looking at this, everything we understand is that we'll be allowed to keep that rule in place, that the new if the federal rule goes into place, it won't really change the state of things here. But we're tracking it, following it, nationally with all the other commissioners as well. But just wanted everyone to know that. Thanks.
Yeah, thank you, Commissioner. I thought I saw another hand up. Is that you, Holly? Did you have a question? No, okay. Okay, I don't see any other questions. Thank you again, Stephanie.
Thank you. Take care.
Good to hear from you.
Bye-bye.
Bye.
Well, next on our agenda, we have Tim Sweeney, who will be joining us and giving us an update on the basic health program. So Tim,
good morning.
Yeah, thank you.
I'm here.
Thanks.
Good morning, y'all. Thanks for having us back for another round of basic health program updates. We've had a busy last couple of months and have done some presentations to the policy board and are going to use some of that content here because we think it has been really well received to sort of take a little bit of a step back in addition to some forward-looking thoughts around continued conversations with carriers around marketplace affordability in 2025 and in the long term, and then some initial conversations around some of the implementation considerations with really a focus on outreach and communications to BHP eligible folks who are currently on the marketplace. So we'll dive in and do a little bit of some of this is recap, but also I think with a lot of these meetings, we also have a lot of people who are who may be newer to the basic health program, and so want to make sure to continue to sort of set some of this context as we move into the next phase of the work. So taking a step back, prior to the public health emergency and the continuous coverage provisions in Medicaid that are certainly a big deal right now, this 138 to 200% of the federal poverty level population was the most likely to go without health insurance of any income group in the state. this is sort of the scenario leading up to the public health emergency. And the next slide shows what happened during the public health emergency as more people were able to stay on Medicaid despite fluctuating income, despite income that maybe went up for a little bit. The uninsured rate, or maybe on this slide, more importantly, the rate of health insurance coverage increased significantly for this income cohort. As shown here, it went from 82 to more than 90% coverage for this income cohort. And again, just for reference, 138 to 200% of the poverty level is about $20,000 to $30,000 for an individual person, about $40,000 to $60,000 for a family of four. So that's the context there. In response to this coverage gain, the legislature directed the agency, directed OHA and DCBS to create a new coverage category to maintain these coverage gains while when the public health emergency unwinding and the redeterminations start. And it created a task force, the legislature did, and the task force recommended specifically that we develop a basic health program, which is a component of the Affordable Care Act, really specifically designed for this income group, for folks whose income is between 138 and 200% of the poverty level. So that is the work of the agency. We've been bringing these updates to you for months as we develop the structure of this basic health program by creating a blueprint that we will submit to the federal government for their approval. So the next slide shows, like, this name in some level is a bit of a misnomer. It really is not basic coverage. The structure that we are developing uses the CCO administered benefit package from the Oregon Health Plan, uses Medicaid benefits, including dental coverage. So it is a very robust service package. There are no enrollee costs, no premiums or copays. It is almost entirely federally funded, and we expect that it will cover about more than 30,000 people who, in absence of this program, would likely end up uninsured, either because they're uninsured now or because they may not make the transition from Medicaid to the marketplace. And that really helps explain why the basic health program is relevant now. The state, as was mentioned earlier, is going through the redeterminations process now and checking the eligibility of everyone on Medicaid. We know that some number of people will no longer be eligible for OHP. And this basic health program will enable folks in this income range, 138 to 200% of the poverty level, to stay in their current plan and not have to make a coverage transition to the marketplace. And we know from extensive data and research that coverage transitions, when people have to move from one system to another, are when people fall off coverage. So this will help maintain coverage, which was a key goal of House Bill 4035 passed in 2022, is to maintain the coverage gains that we've seen in Oregon over the last 2 to 3 years. So who will be covered? I think it's always good to sort of remember what this program will cover and where people will come from. We think about 55,000 folks will move into the basic health program from Medicaid. They're on OHP now, but their income is in this 138 to 200% of poverty range. About 36,000 people will move from the marketplace where they currently get coverage, and about 11,000 people who are currently uninsured will get coverage by the program. So the timeline, and this has fluctuated a little bit, but where we are right now is that the next step, we've had the bill and the task force that developed these recommendations. We have the temporary Medicaid expansion that will keep people in OHP until the program is launched in mid-2024. There's been a public comment and review process for the blueprint itself, and we've certainly been here into other public processes to inform folks about what's happening. And the next step is that in September, the Oregon Health Policy Board will vote on the blueprint. House Bill 4035 directs them to approve a blueprint before OHA submits it to CMS. So that is sort of the next step in this process of developing the blueprint. And then it will go to CMS for their review. We think that will take something like 4 to 6 months as we refine components of the blueprint and get approval in early 2024 for program launch in July of 2024. I'm going to pause for a second before moving on to sort of maybe what is more top of mind for folks of the work that we've done to try to mitigate the impact on marketplace consumers, to see if there's any questions about sort of what the program is and where we've been and where we're going. Okay, great. So now I want to talk a little bit about the work that has happened over the last year or more to develop some strategies to mitigate any negative impact on consumers on the marketplace, and really where this conversation goes from there. Based on task force recommendations, OHA and DCBS have spent really the last year and a half exploring a variety of pathways to generate federal funding to shield consumers from premium increases that really come from the loss of silver loading when the BHP is created. However, without a state-based marketplace, none of these pathways for federal funding were deemed as operationally feasible for CMS. As was mentioned, and I don't want to get ahead of folks later with legislative updates, but that will change in the future. The potential move to a state-based marketplace, as directed by the legislature, will enable the state to overcome many of these operational barriers. However, we don't want to not do anything until then, and so we're going to continue convening the carriers and working with the insurer community to identify and maybe explore state-funded stopgap solutions that could be in place in 25 and 26 until we get to the state marketplace and its increased flexibility. So a little bit of a recap of what we looked at over the last year. We explored first the idea of capturing federal savings that we think will come from the creation of a basic health program, and to use those savings to create a new subsidy program to offset, to defray premium increases for consumers. This would have to be state administered. The federal government wouldn't be able to do that, and thus that created some complexities. In addition to that, we examined and worked with CMS to think through, and worked with the carriers to think through the idea of changing the benchmark plan from the second lowest cost silver plan to the lowest cost gold plan, and the idea that would increase the value of the benchmark plan and thus increase the value of tax credits consumers receive, and again, shield consumers from any premium increases as a result of the BHP. And lastly, as I'll discuss, those two ideas ultimately were deemed infeasible by CMS. CMS proposed that we use a different waiver authority to create a new coverage category for this population that would operate somewhat separately, but kind of like a BHP. And really the barriers to this that also discuss really significant financial barriers in terms of the potential cost to the state to both operate the program and then fund any solutions to mitigate consumer impact. So the next slide helps us show like how we evaluated and really the variables that determine whether these ideas would work. First really is the implementation barrier. How are we going to get funding? How are we going to get this money, additional money, to consumers to offset any premium increases? How do we functionally get the dollars to consumers? Second is really a communications variable. How do we tell consumers what they're getting and what they're eligible for? How do they know what the net cost of the plan might be after we make some changes? And lastly, a barrier of funding. If it's federal funds or state funds, like some questions about how the funding source changes the way in which the money can be used. If we're appropriating state dollars, we may have more flexibility. If we're trying to capture federal savings, we have to play within the rules of the federal waivers that exist to help us achieve some of those savings. So along these three variables, we ran into a variety of barriers and really some federal barriers that prevented us from moving forward. From a implementation and communication standpoint, the federal marketplace really is not set up to be able to administer this state level flexibility. The federal marketplace, healthcare.gov, could not administer the subsidy. If we were to create some kind of direct to consumer subsidy, we couldn't run it through the federal marketplace, and they were also unwilling to prioritize the systems changes that would have been necessary to operationalize a gold benchmark. And from the communication standpoint, similarly, very limited options using the federal marketplace to tell consumers, even if we had some other way to get them the money, to tell them what they're eligible for and how that would affect the prices that they pay on premiums. And then from a funding source standpoint, federal waiver policies really dictate how much money is available, but also how we were able to use the money. And we especially ran into this challenge in thinking through some very simplistic additional subsidy ideas. Flat dollar amounts would be sort of too simple to achieve the federal requirements that around affordability, to make sure that the benefits are that there's not too many winners and losers, to put a general comment on it. But the structure, we were very limited in the type of structure we could have developed and how those dollars might be used. In addition to the federal barriers, we ran into state level barriers as well. We worked with carriers in the fall to really think through the potential ways we could administer a state subsidy given the federal marketplace barriers, and really carriers reported that it would be operationally burdensome for them to administer a flat rate subsidy, for example, through their systems direct to consumers. We also would have faced communications barriers in telling them about that, but those systems weren't necessarily able to do this. And from a state funding standpoint, the timeline in which CMS told us that, like, no, sorry, this gold benchmark plan won't work, was very late in the game in terms of trying to figure out if state dollars would be used. It happened during the session, and it really affected our ability to come up with ideas and consider potential state funded options because of the timing. So moving beyond these barriers, especially those on the federal marketplace standpoint, we do know that based on the analysis that we've commissioned from Oliver Wyman, that the impact on the marketplace will occur gradually over 3 years, and that our understanding as current guidance to the carriers is that because the program launches in the middle of 2024, and we don't expect a significant movement during that year, that the basic health program will not affect 2024 rate setting from the carriers. Also, we know that Oregon will have a state-based marketplace, and that will eventually give us new tools and flexibility to address these barriers, to address the implementation barrier and consumer communications barriers specifically. But that happens in 2027, and we want to try to find a stopgap approach in 2025 and 2026 to help consumers out. So the next slide really starts to get at, like, what are our next steps for this? We have been convening the carriers since the fall at the direction of the task force and at the continued desire to try to figure out some solutions to help consumers. And we're going to continue to convene these meetings to consider new ideas maybe that we didn't think of before, weren't able to consider before, that don't require the federal marketplace or federal funds and could be implemented as a stopgap in 2025 and 2026. This could be a new way to think about a state administered subsidy program. there could be some direct to carrier payments. We want to work with carriers to think about some different solutions, especially if there's a potential to secure additional state dollars to help consumers in 2025 and 2026 as we get to the 2027 and a state-based marketplace. With that, and I really should have said this at the beginning, that Katie Button from your fabulous marketplace staff is going to join us and talk a little bit more about sort of some of this forward-looking work that we're planning. So with that, I will turn it over to Katie, and thanks for joining.
Good morning, everybody. I'm Katie Button. I use she, her pronouns. I'm the plan management and policy analyst for the marketplace. And I've been hanging out a lot with Tim and Laurel and doing some BHP stuff. So I'm going to talk about what we plan for the future carrier tables. So as Tim mentioned, we will be looking into stopgap solutions for 25 and 26, trying to see what we can do to mitigate those premium increases. And then also we'll start to pivot into actual BHP implementation work. So we'll talk about QHP enrollee communications. There will be some definite complications with plan terminations and grace periods, and so we'll want to work through those things so we can coordinate as best we can. And then there may be some continuity of care coordination that we need for folks who are moving to a CCO network that's different from their QHP network and things like that. Next slide, please. And so then for attendees, of course, we love our government relations staff, and you're always welcome to join, and we love to have you. And then depending on the things we're talking about, we may ask for specific staff to attend. We might be talking about operational things, so we'll want your billing staff or your staff who know about tax credit reconciliation, all the enrollment file complications that can come up. Actuarial staff, those are always very helpful. We love our actuaries, love to talk to them about things. And then probably pull in our marketplace liaisons a little bit more, especially as we get into these operational kind of things, because those are the folks that we generally work with at the marketplace as we're trying to figure out how we can best help consumers adapt to changes that we're experiencing in the marketplace. Are there any questions about the carrier tables or what Tim has discussed before I pivot us a little bit into outreach?
Katie, this is Craig. Just maybe not a question, but more of a comment. I'm very encouraged that this is happening. I think maybe people on the committee might recall the end of last meeting, I was thinking that maybe it was something that we might have to convene, but I'm glad to see that there's the leadership from the OHA and DCBS to do this. So this is something we'll definitely support and glad to see.
We're looking forward to more conversations as well. All right, well, let's go ahead to the next slide, and then we're going to pivot to outreach and communications. And I would like to just have a disclaimer that I am not an outreach and communications professional. I'm not the person who should be telling you a lot about communications and outreach, but we have been starting to pull things together. This is a very high level timeline. Will definitely change as we start to nail down more details and things, but wanted you to know that we have been starting to think about it, and this is what we're starting to think about. So right now we're definitely in the planning stage. We're information gathering, finding out what do we know, what do we not know, who knows what we don't know, so we can get those questions, starting to pull together all of the various folks who talk to all of the various groups so we can make sure we're covering all the things that we need to cover. And then early next year, we'll start working really hard on materials, so outreach materials for consumers, training for all of our partners. We're definitely going to need our partners on this, so we want to make sure that they're in the loop. And then we're going to do sort of a soft launch in June through September of just making sure folks know about the BHP and how to get into it. But we will plan to put most of our efforts into our normal open enrollment outreach, which we start in October. And so we'll have some specific BHP components to that outreach. Next slide, please. So there are three sort of audiences and entities that go along with those audiences that we're thinking about right now. So first is the folks who are transitioning from Medicaid. So those are the folks who are currently enrolled in OHP. And so then, of course, the CCOs and the community partners who work with those folks will need to know how to help those folks if they're having issues, if they don't know about the BHP, don't understand what's happening to them. And then the folks who are transitioning from the marketplace will have the QHP enrollees, obviously our carriers, CCOs who are going to have those folks enroll. Our insurance agents and our community partners will be really important in making sure that folks get where they need to go and do all of the things they need to do to terminate their marketplace coverage and all of that. And then lastly, the uninsured folks who will hopefully be coming to the BHP. So we'll have The groups that work with those will have the CCOs who will be taking them. Hopefully we'll be able to get our insurance agents and our community partners involved in helping those folks. And then lastly, we'll want to make sure that we work with various community groups to help the uninsured folks who don't have coverage. Next slide, please. So then a few things that we're thinking of as we're starting to kind of think about actual implementation are ways that we can help make sure that the marketplace folks aren't experiencing disruptions in care, but rather really moving when they want to move, when they need to move, and getting all of the things done. So there may be times when it's appropriate for someone to stay in their marketplace plan. They may have a surgery coming up. They may have a course of treatment that they're getting close to completing. And so we want to make sure that if folks need to stay in their marketplace plan, that they know how to do that. And then one of the things that all of the marketplace folks will experience is similar to what happens today if someone has been enrolled in the marketplace and then has their income go down and they're eligible for Medicaid. CMS will send a file to Medicaid, but it doesn't terminate their marketplace coverage. So there will be a lot of folks who need to have assistance in making sure that they know when to come back and terminate their marketplace coverage. And then as folks get closer to October, November, December, they may have auto enrollment that will go through even if they have been determined eligible for the BHP. So we'll need to make sure that we're telling folks how to stop that auto enrollment, or there are some things that both the carriers and individuals can do if the auto enrollment actually does go all the way through to January and become effective. So we can help folks get that terminated correctly. There will be some differences for folks who are in an area where there's more than one CCO, particularly for folks in Portland who have the option of health share. There's options within health share. So we'll want to make sure that we're helping folks know how to get to the CCO that they want and need, especially if they want to continue with their providers. For example, if a person's enrolled in Kaiser, we'll want to make sure that they know how to get into Kaiser inside of health share so that they can keep that continuity. There will be some places where folks will move from having potentially 6 carriers to choose from to 1 CCO. So again, we'll want to make sure that folks know what to expect and how to choose a new provider if their provider isn't included in the CCO network. And then last, just making sure folks know where to go if they need help, if they have questions, making sure that folks know about our Get Help tool so they can find an agent, find a community partner. We know that folks do better when they have someone who is a trusted resource to guide them through this process. And then obviously having customer service numbers for them to call for when they have questions. Next slide, please. So now we'd like some feedback from all of you. Are there any strategies that you have seen in other programs that you've used yourselves that you think would be particularly effective in moving folks from the marketplace to the BHP? Drew, take it away.
Morning, this is Drew Tara of Providence Health Plan. And a member. Actually, it's not so much a recommendation. I know that's what you're specifically asking for, but I guess it would fall in the category of recommendation. If our communication plans are, in fact, overly effective, do we run the risk of faster migration from the marketplace to the BHP than what was originally presented? And that Tim had noted, the expectation is a gradual movement from marketplace to BHP. But I guess it's an odd way to say if the state's communication plan is effective, and we hope it would be, then the gradual migration wouldn't be gradual; it could be all at once. Does that make sense?
That does, and that's really good feedback. I'm going to write it down and take it to the people who actually are comms professionals. I'm sure that there are a lot of things actually that, we need to be careful of not overwhelming any of our groups. Like if you dump 30,000 people on an agent, they're not going to be able to help all of those people, right? So there's a lot of benefit, I think, to spreading it out. And so the people who are comms professionals will definitely take that into consideration.
And thank you.
And if I can also respond really fast, I mean, I totally appreciate that comment and just would add maybe a caveat that, as Katie mentioned, part of this strategy is going to be making sure folks who don't want to switch in the middle of a plan year know exactly what they need to do to stay in their current plan. And so hopefully, to your point of if our communications strategy is very effective, we intend that it also means effectively reaching consumers who want to stay in their current plan and not make that move in the middle of the year, or if they want to stay in their current plan into 2025, right? That folks know how to do that if that's what's best for them. But in general, I totally appreciate your comment about making sure that we're not undermining what we're saying in terms of how we expect people to move in actuality.
Thanks, Tim.
Mary Beth?
Yeah, so I'm not super in the weeds on redeterminations, but it seems like that process has been pretty successful so far in terms of reaching out to populations like in chunks. And so I feel like that might be a really effective strategy, especially given Drew's point of not overwhelming people and increasing the speed of that migration too quickly, to reach out in chunks, and then making sure that we're also tracking responses for people who, you know, want to stay on their plan through 2027 or through 2025 when that move is necessary, so that we're not reaching out multiple times and getting the same responses or overwhelming folks who have already been contacted with and made their choice or understand what's going on. So not building in protections against redundancy.
Thank you, Mary Beth. It looks like Ohm has a question.
Yes, good morning. In regard to the second bullet, that what are the topics related to BHP in the marketplace, I want to ask about the equity in terms of access to the doctors. I heard that, you know, Oregon Health Plan have hard time seeing the doctors, and even in the marketplace or direct market, they have a difficult time. So how are you going to do that? And I want to have some clarification, maybe next slides, about the premium in the marketplace. You from what I understand, that you're using the BHP as a stopgap, but we try to save 50,000 of the people to have the BHP, but what about the other 100,000 who on marketplace would be affected by increasing premium? Thank you.
So I can take a first crack at this, and maybe I'll start with the second piece and try to remember exactly what your first question was. Sorry. And you know, we have that has been a big topic. Like, what is the premium impact and for folks who remain on the marketplace, and while about 60% of the marketplace enrollees above 200% of the poverty level who are getting subsidies now, about 60% of them will see, even by 2027, cumulative premium increases because of the BHP that are $25 or less. So still the majority of those premium increases, while not zero, are lower. But certainly some folks will experience higher premium increases, and that is really exactly the purpose of continuing to convene the carriers, is to think through ways to address that, ways to help improve affordability in 2025 and really and beyond, so that while we're working to make coverage more affordable for folks between 138 and 200% of the poverty level, we're also continuing to work on affordability issues for folks over 200% of the poverty level. So that is, you know, exactly the point of these carrier convenings that we're gonna keep doing. But in thinking about your question, I thought about the second piece and kind of forgot about the first. And Nikki, please chime in.
Yeah, I want to just chime in, and these are really good questions, and just want to acknowledge that these are definitely things that we are thinking about. So my name is Nikki Olson. I she, her pronouns. I'm one of the managing sponsors supporting the Basic Health Program policy development. So, you know, recognizing that access to care is a complex, you know, series of things that impacts people in different ways. So having coverage in the first place is one issue that we're trying to address with the Basic Health Program, is making sure folks stay covered. Provider networks, as you mentioned, is critical, and then ability to afford to go to a provider is also another layer. So access is kind of more than just network, but as far as thinking about the CCOs and their networks, we are working really closely with the CCOs to prepare for the basic health program. Over half of the people that we anticipate being on the basic health program are currently in CCOs. So we, as far as kind of having a handle on access, that's going to be something that we continue to work with the CCOs on, and can have more kind of tracking of that as we watch enrollment. Right now, we're enrolling folks into a temporary expansion category that are already in Medicaid, and we can continue to kind of track and monitor access as a part of the CCO work that already exists. So appreciate those comments and agree that coverage is the first step, and making sure access, there's not barriers to getting to providers, or previously what we think is driving a lot of issues is being able to afford going to a provider. So we'll continue to report out on that and be accountable to that layer of this process.
Thank you.
Thank you. Paul, I saw your hand go up for a minute. Did you have a question or comment?
More of a comment, and it kind of addresses what Tim was talking about and also what was talking about, just that, happy to hear the, carrier meetings are going to continue, and sort of particularly thinking about the communication front to marketplace members who are going to stick around and may face, larger than expected premium increases. Like, I like step one as being, hey, can we prevent those larger, premium increases? But then to the extent that the carriers in the state and everybody, we can't find a path, it then does become, all right, so how do we communicate with those members? How do we reach out to them? Because when I think of this, when I just think of myself, it's the surprise that's going to cause some of that irrational disenrollment, where they don't have time to plan their budget, and you start focusing on the change more than the absolute value that you're looking at. And so to the extent that, between the carriers and the state, we can get in front of that, not scare people, but give them the time to sort of figure out, hey, do I need to do something differently, and not just sort of get that surprise when they log in for open enrollment. And so I think that's like a, plan 1A or something for the carrier tables as well.
That's great feedback. Yeah, go ahead.
Thank you, Paul. I appreciate that. I was just going to say thanks. I really appreciate that thought, and look forward to those conversations.
Mary Beth, you had a comment or question?
Yeah, just on the same topic, I think that we've kind of gotten to the key point, which is that communication, like Paul said, but I also wanted just to bring up the fact that Oregon is pretty unique in pursuing like these options for people who are being disenrolled for Medicaid with the BHP. I was reading about Tennessee the other day, and in the first month of redeterminations, they disenrolled over 30,000 people from Medicaid. And Oregon's experience has not been that. Oregon has been keeping people on Medicaid. So I really just wanted to put that into perspective for this group, and thank OHA for their efforts on that, and for bringing these topics to this advisory group and other advisory groups to make sure that we're on the right track.
Yeah, it's good to take a step back and acknowledge that we're doing a good job there. I think when we're thinking solely of the marketplace, we do have some concerns going in the future, but I think Oregon is doing a good job there. Katie, I had a question for you on the on your first topic, the strategies of moving people successfully into the BHP. I just wanted to make sure I understood that really the only people on the marketplace that could remain on the marketplace in 2025 are those that have auto re-enrollment. Is that right?
Yes, and they need to have given CMS approval to redetermine them. So everyone is auto enrolled. It's very complex because all of the things at healthcare.gov are complex. But everyone's auto enrolled. But if you have given CMS approval to redetermine you, then those folks will stay. If otherwise, they'll be auto-enrolled but without tax credit.
I'm pretty close to this, and I don't think I quite understand that. So I guess that's part of, I'm sure that went into the estimates of who might remain in the marketplace, as Drew was talking about earlier. But that's the part I'm not sure if people understand what their status is and whether they can, I mean, do they have to make that election for 2024 open enrollment, or can they make that election for 2025 and remain on the marketplace?
That is a really good question. I'm not 100% sure, and I'm going to add that to the list of things because I believe that at any time you could go in, it's just a checkbox.
Oh.
But the question will be, does that count as, is that something that's going to count as an application update that would make CMS redetermine someone and move them to the BHP at that point? So let me put that on the list of things that we are tracking down to make sure we 100% understand how it will work.
Okay. Well, thanks. Yeah, thanks for doing that. And I don't want to drag us too far into the weeds on that. But I think maybe to your question, then you're really asking for those that really won't have an option to stay in the marketplace, how do we ensure that they take advantage of the BHP? Is that what you're asking?
I think it can be either. I think like you know, like you said, like there are folks who will want to stay, and we want to make sure that those folks know how to stay. And then there will be folks who want to go, and we want to make sure that they know how to go. And then there will be folks who maybe updated their application and didn't know it was going to move them over, and now are like, I don't know what this thing is. So there are lots of things that people will need help with. And so we're just trying to start writing things down, start tracking things down. The question that you asked about, you know, if they haven't already told CMS they can be redetermined, can they do it? That's a perfect example of what we're trying to track down now, so that when we are ready to roll out communications next year, we will know all of the things and we'll have, you know, answers for people who have questions.
Okay, that makes sense. Yeah, thank you. And I think on top of that, as Paul was mentioning, also communicating what it might mean for them financially if they stay, and that will be part of the equation. Well, good. Are there, do you want to move to your second question if we haven't covered that already?
Yes, please. Are there other topics related to the BHP in the marketplace that are important to you, or any other just general questions Tim and I can answer?
Go ahead, Lindsay.
Thank you. More just a kind of a brief comment about our experience with redetermination and what it might mean for this. In some respects, I think that BHP messaging is more complex than redetermination. There are more choices involved, perceived or more paths, it sort of seems like, for that messaging for people. In terms of the questions we're getting, quite a bit of our effort has been in the community roundtable and just tools providers can use and provider education materials as they get questions from individuals seeking care from them and just looking for help. So I was just wondering, going forward, doesn't have to be today, I'm curious how the provider and community education strategy might evolve, drawing lessons from redetermination, because we're still pretty early in that process. I think I'm not saying it's going poorly, but actually to some extent, we just don't really know. And more story to be told. So I'm curious about how you're taking that input.
That is something I'm adding to our list of things to make sure that we are looking at and listening to. Again, as I said, we've just barely started to pull things together, and I am not a comms professional. So I'm sure that once we start to pull things together, there will be a lot of people who know all of the groups that we should be talking to, including providers.
Thanks for adding it to your list. I know that you can't be all things to all people. It's just been our experience so far that I think there might be a parallel.
And this is exactly the kind of feedback we were hoping to get today. So thank you so much.
Okay, any other feedback? Sounds like this is sort of an open item or for discussion if there's any other feedback about the basic health plan. concerns about the marketplace, if anyone has those. Okay, well, it doesn't look like that. Thank you both very much for this update. Again, just want to tell you that we're encouraged to see that we're going to continue the carrier tables and look for ways to help mitigate the impact on the marketplace, but keeping in mind that this is a good thing for coverage for Oregonians. So great work by everybody that's involved in it. So we are a little bit early in our agenda, which is good. At this point, I think we can move to public comment, even if we're a few minutes early. So I'll open it up to public comment. Okay, I don't see any, and we are now due for a 10-minute break. I think we can just stick with that.
Yes, we can. So 10-minute break. If we can all come back at 10:15, that would be fantastic.
All right, we'll see you then. All right, welcome back everybody from the break. We're a little bit ahead of schedule, so we'll move next to the topic of the 2024 rate filing and get an update from Tasha and Katie.
Hello, everybody. My name is Tasha Sizemore. I am the Life and Health Program Manager for the Oregon Division of Financial Regulation. My team is responsible for what we consider the front end and the back end of product regulation for health and life insurance products. So we look at the forms and rates before they go to market to the consumer and review them for compliance. And then we also, once the product is on the market and out there in the wild, we take complaints from consumers and resolve issues. Since the ACA, have been working very closely with the marketplace. There's a lot of overlap, especially in the individual and small group market. So I am here today to talk to you all about the 2024 individual and small group rates. I would like to start by saying that we did have to adjust our schedule this year. Normally, we would have had rate hearings by now, and we would have proposed final rates out to insurers. However, due to waiting for the legislature to finalize some key legislation around House Bill 3008, which I think Katie's going to talk about in part here in just a minute, so I'll save that for her. We decided to pause and sort of see how things shook out with the legislative stuff. So we moved rate hearings to August 4th. However, I did want to share a little bit about what was filed by insurers this year. So generally, overall, the actuaries are telling me that what has been filed continues to show market stability, but 2021 claims, which is what the actuaries are reviewing right now, are coming in higher than previous years. We did have one insurer exit a market. It was Samaritan exiting the small group market. Otherwise, things are pretty much unchanged. I do think we have one carrier, and I'll check this in just a second. I do think we have one carrier potentially entering an area that they had previously exited. But otherwise stable on the number of insurers in the individual and small group market participating throughout the state. Rate changes on average that were filed are following medical trend, with an average rate change in the individual market of 6.2% and in the small group market of 8.2%. There are some legislative changes and just some social impacts happening right now that the actuaries took a little bit of a look at through rate review this year. So Katie, like I said, is going to talk about House Bill 3008 and access to primary care. However, I would just like to say the news over the past year has been filled with ongoing stories of the struggles of nurses and doctors and healthcare providers and strikes and those sorts of things. So we did proactively ask insurers some questions about the impact of those events on our market. The responses I have not gotten all the way through yet, but I will say that many insurers have anticipated this and worked it into their rates already. So that is one of the major things that we are looking at as provider contracting costs. The other items the other thing that has been asked about over the last couple of years, and with the close of the pandemic, I thought I would just mention it, the close of the pandemic. But we did ask again this year about the impact of COVID on rates, and consistent with last year, we are continuing to see that have very minimal impact at this point. Like I mentioned, there are other social factors driving rate increases, but those are staying, it looks like, on point with trend generally. The other thing that I would say, just in closing, is as with all years, rate hearings are available and accessible to the public, and they're conducted virtually entirely now. So I really encourage folks to participate, and encourage, if you are a consumer or know someone who has an individual or small group rate, we would love to have their participation in the rate hearing, just having them listen in to what insurers are saying. And then consumers and others can also submit comments on our website, and I'll drop that link in while Katie's chatting, if that is something that you are interested in. Having been born and raised in Eastern Oregon, hopefully with virtual hearings continuing, we can start to get more participation from the home side of my state. But otherwise, things are pretty stable, and I guess no news is good news, except for everything that happened prior to break. So any questions for me from folks? Okay. I'm going to drop the link to the rate hearing page and where consumers can submit comments into the chat for folks, and my email in case anybody has any questions. But as always, it was great to be here. And Katie, I think you're going to talk about some plan changes.
Woo, exciting stuff. Thank you, Tasha. So there are some changes this year. Every summer I come to HIMAC and I talk about what we can expect for the next plan year. So let's talk about 2024. So Regents is going to discontinue 3 plans. They're going to crosswalk consumers to the same network, same metal tier, just slightly different plans. So we always recommend folks double check their plan that they're being crosswalked to anyway, and make sure it's still working for them. So folks will have an opportunity to change plans if they don't want those crosswalked plans. And Regents will send out discontinuation notices so that folks know that those plans are being discontinued and what the new plans will be. Next slide, please. Tasha mentioned it, she hinted at it, but MOTA is re-entering Deschutes County after several years of being away. They're going to offer their 11 affinity network plans there, so that'll be nice for consumers to have another choice there in Deschutes. And then Pacific Source is discontinuing their catastrophic plan. Those folks will be crosswalked to Navigator Bronze. It'll be kind of similar to the Regents staff. They'll get a discontinuation notice. They'll have an opportunity to choose a different plan. I will just note that this was our last catastrophic plan, so Oregon no longer has catastrophic plans, but they had very low enrollment. I don't think they were that popular with consumers, so just wanted to note that. Next slide, please. This is a map that our wonderful friends at DFR make every year, and every year I add it to our slide deck for you. You can see that we have 4 carriers in Lincoln County. Most of our counties have 5, and then some of our counties have 6 carriers. Next slide, please. Okay, so there is kind of a big change this year to the standard plans and some of the non-standard plans, and I want to make sure that we talk about it because it's going to be a little hard to message to consumers. So Senate Bill 1529 in 2022 was passed, and it required health plans to offer 3 free PCP visits. However, there are mental health parity requirements that get a little funky. So the carriers worked hard to get an amendment into House Bill 3008 that would amend 1529 to allow it to meet mental health parity requirements. So instead of being free, the office visits will be $5, and they are offered on PCP, mental behavioral health, and substance abuse disorder visits instead of just PCP visits. Next slide, please. So this requirement goes into place for all off-exchange plans. So any plan that's offered off-exchange has to have the 3 $5 visits. All small group plans have to have the 3 $5 visits. And then for individual on-exchange carriers, they must offer at least 1 individual on-exchange plan that covers these office visits. So because they all have to be offered in small groups, then the standard plans must include the visits because the standard plans are offered in both individual and small group. So some carriers are just including the visit in the standard plans, and then MOTA and Providence have some of their non-standard plans with these 3 $5 visits. I neglected to put it on the slide, but I need to call out that HSA eligible or high deductible health plans, those that are eligible for use with an HSA account, cannot contain these three $5 visits because those plans are set up to only offer preventive services ahead of deductible, and all other services must be subject to deductible, so they do not contain these three $5 visits. Next slide, please. So on healthcare.gov, there unfortunately isn't a way for it to notify consumers that there are visits ahead of deductible or at a different cost sharing. So consumers will have to click the view limits and exclusions. It's a little link there. And when they click it, next slide, please, there will be a pop-up. And this is the language that we are asking carriers to include on the standard plan so that they all have the same language and so that it's hopefully as clear as can be, but it is quite complex because it is three $5 visits, but they're spread across these several benefit types. So primary care provider, other practitioner, outpatient mental behavioral health visits, or outpatient substance abuse disorder visits. Next slide, please. On our window shopping tool, which you can find at oregonhealthcare.gov/window shop, our vendor is putting a special flag on the plans that include this benefit. So they'll put this flag on the standard plans, and then for the carriers that are offering this benefit in their non-standard plans, they'll also put the flag there. And so you can see that it says $5 visits, first 3 PCP and mental health. And then if you hover over that, then the pop-up will come up, which will display the same text as before. Next slide, please. One of the advantages to the window shopping tool is that it automatically displays any information that the carriers put in the explanations and exclusions text. So this is actually Pacific Source's 2023 catastrophic plan, and I chose it so that you can see how the chart, or excuse me, the cost sharing is no charge after deductible, but then you can see in the explanation text that it says the first 3 office visits are covered in full. And so if we were to use the 2024 standard bronze for an example, it would say that the charge is $50, and then it would say 3 $5 office visits, that whole block of text there. And so that automatically displays. So hopefully if folks are looking at our site, it will be more obvious that, oh, something has changed. Oh, there's 3 $5 visits. Oh, what is that? And people can look at it more. Next slide, please. So in order to accommodate these office visits, CFR and the marketplace had to make some significant changes to the standard plan. So I wanted to highlight those for folks. MOOP stands for maximum out-of-pocket amount, in case you are unfamiliar with that acronym. This is the standard bronze plan. So DFR does the standard bronze and the standard silver. And so they do that via rulemaking. So the standard bronze, the MOOP and deductible increased, the specialist visit increased, and then the generic drug copay increased as well. Next slide, please. So this is the standard silver, the base variant, so the non-cost sharing variant, and DFR increased the deductible and the MOOP to have that meet AV. Next slide, please. So then the marketplace does the cost sharing reduction variants of the silver plan and the gold plan. So in order to make the 73% cost sharing reduction plan meet AV, we had to do some interesting tweaking. So we increased the MOOP and deductible. We increased the specialist visit to match the base plan. It had been a little bit lower for a few years. And then we also increased the preferred brand drugs to, again, match that base non-cost sharing variant. Next slide, please. This is the 87% CSR plan. We were able to get it to meet AV by increasing the deductible and the MOOP a little bit. Next slide, please. Thank you. And then this is the 94% plan. So again, just a little bit of increase to the MOOP and deductible in that plan will now meet with the 3 office visits. Next slide, please. This is the gold plan. The gold plan is a lot easier. AV is higher on that plan. So we just had to increase the MOOP a little bit to get that plan to meet. Next slide, please. So then I wanted to do a reminder. I know that we have told you about our affordable employer coverage tool before, but with folks maybe coming back into the workforce, coming up on open enrollment, I just wanted to remind everyone that we do have a tool that is a calculator that allows people to see if their employer coverage is affordable for both an individual and their family. So the links to the English and Spanish versions of the tool are here. It's also available on our homepage. So if you go to our homepage and you look for the picture of the people at the table, if you click on that, it will take you to the tool. Next slide, please. And then within the window shopping tool, there is also a link. So on the second page, so after you've put in the zip code, when you go to the second page and you enter in who's in the household, there is a checkbox that you can check for offered affordable coverage. And if you don't know if the coverage is affordable, there's a little arrow there. When you click on the arrow, the visit affordability estimator tool link will pop up, and you can click on that link and it will take you to the tool, and then you can do the tool, and then you can come back and select whether or not the coverage actually is affordable. So I just want to make sure that folks know that that is out there. I will be coming to agents and community partners to talk about how we can do more explanations to consumers as we're getting closer to open enrollment, so that we know about the office visits. And if you have any questions about what we are expecting for 2024, I'm happy to take them.
Any questions for Katie?
More of just a comment on like the 3 office visits and how it represents itself on healthcare.gov is just absurd. And it's just one more thing on the stack for why having our own exchange will be a good thing for consumers. So I just wanted to, as you went through that, I was like, that is just so dumb. That, sorry.
I completely agree.
Thanks, Paul. Any other questions? Well, I just wanted to thank you, Katie, for all your work on that. I'm sure meeting those AVs was not simple. Drew has a question, though.
I do. Thank you, Craig. And Drew Tarrant from Providence. Me and him. Katie, I think you mentioned that you said actuaries were reviewing 2021 data, but I think, is it actually 2022 experience data that's being reviewed right now? Or is it in fact 2021 data that they're relooking at?
That would be a question for Tasha if she's still on,
Oh,
and
sorry.
if not, I can circle it back. No, that's totally fine. We work really closely with DFR, but they do control the rates, so I try to be very careful about what I say about rates.
Okay.
So if Tasha is not on, I can take that question back.
Thank you. I guess I have a follow-up question, if you can take that to Tasha, which would be, was there something unusual about the 2022 or 2021 data, whatever data was being looked at?
Okay. It looks like Ohm has a question.
Yeah, thank you, Greg. Can you explain the exclusion of the 3 visits one more time, please? As I agree with Paul that it's a little bit odd.
Yes. So Don, can you go back to the slide that has the pop-up language? So it is 3 $5 visits. They are applicable for primary care, other practitioner, mental behavioral health outpatient, and substance abuse disorder outpatient visits. So the first 3 of any of those visits combined are $5. And then after that, whatever the plan charges. So what if there's a copay, if there's a deductible, however the plan is structured, then the normal office visit copay or coinsurance applies after that. Does that answer your question, Om?
No, but there is some exclusion on missed appointment on some get acquainted on that one on some slides.
Right.
It was from the HSA?
Yes. So that is, I was trying to, Dawn, can you go to the, I think it's the next slide or the slide after that. I was trying to show what it looks like. So this is Pacific Source's catastrophic plan. So I was trying to show what it looks like if a plan does have office visits that are separate, that are a different charge from the normal charge. So Pacific Source does have their own exclusion language that they add on their plans. And so that would be subject to the carrier. If they have a language like that, they would add that. But the explanation language would explain that it's 3 $5 visits spread across those visit types. So the missed appointment is carrier specific. Does that explain it more clearly?
Yeah, thank you.
Mm-hmm.
Okay, any other questions for Katie? All right, well, once again, thank you for the presentation and all the details. It's great.
Thank you.
Yeah, thank you. All right, next we're going to move on to Phil Schmidt, who will give us an update. And last time we heard from him, things were stalled, and I think that logjam cleared. So looking forward to hearing what you have to say about that.
Well, about the logjam clearing, that was above my pay grade. But greetings everyone. Philip Schmidt. I use he/him pronouns. I've seen many of you before. I'm on the OHA government relations team. I focus on health policy and analytics, where the marketplace sits, and then also the Medicaid program. And yeah, Chicky and the marketplace team asked me to come back and sort of wrap up, the legislative session with you all. As noted, it was an odd one, and I think, as I remember, where I've intersected with you all has continually been odd moments. I think in the first instance, we sort of were very early in the session. It was like a sort of a blizzard of bills, and we were trying to figure out up from down alongside having a new governor. And then the second time I visited with you all, it was the middle of a walkout that lasted for quite a while and put a pretty significant curveball into the legislative process. But it is all over. They did, as you know, come back from the walkout and pass a lot of bills, pass the budget for OHA, and some key policy priorities that we were interested in. And I just wanted to, what you see on your screen is how we went into the legislative session. These were our key goals and overarching sort of strategic imperatives. Obviously, to eliminate health inequity by 2030 was the first of our goals, and one of the measures against which we judge bills and policy ideas and funding proposals. You've heard quite a bit about the PHE ending and the move to a basic health program and those sorts of things. That policy imperative really fell into the second bucket on the screen, which was to protect the gains in coverage that Oregon has experienced throughout the pandemic, and to continue to expand coverage as we move forward. The governor was very clear that one of her key priorities was for us to focus on behavioral health and fixing a system that's really not working for people and Oregonians in many ways. The next two bullets really focus on that. And coming out of the pandemic, we all could see that we need to keep working on our public health system. And then last, the governor really directed us to focus on, in the ways that we intersect with it, on housing access, and to see what we can do to help fix the housing and homelessness crisis that our state's facing. You can go to the next slide. So I'm going to really breeze through some of these and just sort of say I'm happy to connect you all with some of our government affairs or our program folks on topics that I don't cover. One of which obviously is this slide, the opioid crisis. But they did pass quite a few bills to try to provide more resources to deal with the problem of opioids. And see, there were 4 key bills that OHA was involved with or was paying close attention to. That are in that vein. We can go to the next slide. As I said earlier, behavioral health was a real focus. There's quite a bit of, obviously there was a technical fixes to Measure 110. One of the situations that kind of came down to the wire was the 988 crisis line. And how to fund it. They eventually did increase the tax on mobile phones to help fund that resource. And as you see, there's several other priorities that we were tracking, and there's quite a bit more in the budget that we received funding to keep working on the behavioral health policy area, and to try to make some progress. You can go to the next slide. Oregon State Hospital was a focus. The first bill, for instance, is Marion County, Salem. Folks were feeling a unique burden that people who weren't from Marion County, when they were released, were being sort of left in Marion County or in Salem. So that's the sort of fix that feels a little adjacent, but is really necessary. We're going to continue working on Senate Bill 431. There's quite an issue with folks that are in the judicial system and also in behavioral health crisis of one sort or another, and so there's quite a bit of work needed there. We can go to the next slide. This, is more my bread and butter, health policy. I think I probably should have highlighted it in OHA approved colors, but SB 972, which was authorizing us to start the process of moving to a state-based marketplace, did pass. It was bipartisan. There was bipartisan support, not unanimous support, but bipartisan, which was great. And there was, to Chicky and the health insurance marketplace's team's credit, there wasn't, it was pretty painless. Folks really sort of understood the benefits of moving to a state-based marketplace, and they understood the challenges. I think one of you was just pointing out one of these that we face in using the federally facilitated marketplace, and it really was smoothly. We would sit down with legislators or their staff and sort of say, here's what we're thinking, and generally there were head nods and not a lot of like, why are you doing this? What about this downside? Chicky, because this is so instrumental, I would invite Chicky if you have additional comments on sort of the process of getting the bill across the finish line, or if you will be updating HIMAC in the future on sort of the steps that you'll be taking under the bill's provisions to make these moves. So I invite you to talk about the process of getting the bill across the finish line, and let me and the committee know what y'all are thinking about, keeping them updated about implementing it.
So your question came into two parts, so I'll take the last one first. Yes, this will be SBM transition. We are covering that in later slides. And this will definitely be a part of the committee's work plan for 2023, 24, 25, 26, 27 onwards. It'll be part and parcel of the advisory committee's scope of work, if you will. In terms of getting this through the legislative process, first off, I would like to thank everyone, the committee, DCBS, OHA. This is not a new topic, especially for the committee. We have been advocating for this since at least 2019. I know I've been advocating for this since I started this job 6 years ago. It was a very long marathon, I think is a good way to say this, but it wasn't without partnership. So thank you everybody for your support. There was a lot of conversations. I can't even keep track. I did not log every single conversation I've had about this, but we are here. We are at the starting line. It's going to be another marathon, if you will. We just finished one. We'll start a new one. And I'm looking forward to the work with you all. Thanks, Phil.
Yeah, thank you, Chicky. I probably should have acknowledged the reason it was smooth was because of those many years of work that both Chicky and the team and then you all have put in on sort of educating and talking about why this is a necessary change. So yeah, and as Chicky will, I'm sure they are a incredibly organized team. So the slides later will be informative about how this is all going to work. I think the other bill on this slide, just to be aware of, is the Universal Health Plan Governance Board. Also, sort of colloquially, it's like this is the single payer bill. Many folks have heard of. This is going to set up a governance board, sort of at DCBS. However, it's going to be an independent board. It'll get its own executive director once it's in progress, or once it's seated. They're directed to sort of look at and make plans for how Oregon would transition to a single payer system, and to look at what that all would look like over a series of years. OHA will be consulting, but we, as I said, DCBS is sort of setting the structure up, and then it kind of spins out. And then I think DCBS and OHA move into sort of more consultative roles, provide data, et cetera. So we will not be leading this effort, but a lot of interest in this. It had many iterations throughout the legislative session. This is where they landed, and we'll be tracking it closely as it moves forward, the work and the underlying ideas. I think we can go to the next slide. So it's also sort of my bread and butter, maybe a little bit adjacent to some of the topics that you all pay close attention to, but we did push back the CCO contracting procurement process by 2 years. General feeling in the legislature and at governor's office and the agency was we have a lot of balls in the air doing a new procurement right now that's community led and really focuses on what the CCO and the Medicaid system should look like, was just not something that OHA had capacity to do. So we have another couple years, and we'll begin, even though we have 2 more years, we'll be starting the planning process immediately, and it'll be an interesting run up. HB 2002, in part was the cause of the walkout. It is a bill about reproductive rights and also a gender affirming care mandate. In the end, it did pass. It was changed somewhat from the initial bill that passed the House chamber before the Senate folks walked out. And OHA and sort of the programs that we work on are going to be looking at how we implement the parts of this bill that we do. So, for instance, the Medicaid program will be looking at updating its offerings in the gender affirming care space to comply with the law. And PEB and OEB, I think, will be looking at the same, and it is a mandate that's for all carriers in the state, public and, well, at least the ones that the state can influence, not Medicare. Last, SB 216 was something that we paid close attention to. This was not changing anything in terms of a mandate around race, ethnicity, language, disability, Real D data, and sexual orientation, gender identity data, but rather ensuring that it was treated with confidentiality, because prior to this bill passing, it was not treated as PHI from a data perspective. So we wanted to update the statute to make sure that OHA, as it was handling the data, and folks that were handling it in partnership with us would treat it as confidential, so that folks would feel comfortable sharing it, and knowing that key private information would be confidential. Flu vaccine for all, I'll just briefly touch on that. That actually was allowing pharmacists to administer the flu vaccine to children down to 6 months of age. So we mislabeled it. The flu vaccine is available to all already. It was just an update to how we deliver it. I think next slide. And I think I'm almost there. I just want to make you aware that there was a real thrust around challenges that providers, particularly hospitals, but providers generally are facing with workforce. The Organized Labor Hospital Association, other providers came together with sort of a key package that they all want to agree on. The first piece of it it says nurse staffing ratios on the slide. It's really hospital staffing ratios, because they extended it to other workers within a hospital, and provided ratios and new penalty structure, so that workers under the terms of this bill would have a little more support against, I guess, overwork and too many patients and that sort of thing. We also were funded to with state funds to put some more incentives behind training and apprenticeship opportunities to try to open the pipeline a little more for workforce. And a related piece was that providers, in particular, for hospitals and health systems, wanted not to have the costs of their investments in frontline workers count against their progress towards the healthcare cost growth target. And so that was exempted in statute. I think we'll go to the next slide. Yep. And so this is our team. It's in your packet. You can see sort of how it breaks down. So if you have by issue areas, if you have key questions on behavioral health or state hospital, feel free to reach out to me, but I will probably direct you to my colleague Kaz for more. But no wrong doors. We're always happy to answer questions to the best of our ability and route them internally. And I really appreciate working with you all. Happy to answer any questions. I think my time is up fairly soon, but let me know if what questions you have. Perfect.
No, don't see any questions. That was very comprehensive, considering we weren't sure last time you talked to us whether any of these bills would get passed. So that's quite a few bills and a lot of good things happening. So thank you, Phil, for that update.
Yeah, thank you all. And I look forward to staying connected with you all. And please do reach out if through committee business or your own personal interest, you have questions about bills or legislation. We're always happy to help. And of course, Chicky and the team can help you too.
Yeah, and I appreciate you providing the OHA's perspective on what you want to accomplish as well. So that's good context. Thanks.
Thank you.
Yeah. Okay.
Thank you, Phil.
Good. Next up.
Okay, let me take a quick deep breath, because just going through Phil's presentation, there's a lot that OHA is definitely going to be working on the next few years, and the marketplace is no exception. So as we all know, drum roll please, and maybe applause, internal applause, Senate Bill 972 and our SBM transition has been passed and has been signed by both the President of the Senate and the Speaker of the House. It is currently awaiting, I love all those. That was really nice to see all of the virtual hands clapping, so thank you all for indulging me. So Senate Bill 972 is our SBM transition bill. This allows us to transition away from healthcare.gov, ideally by November, on or after November 1, 2026 for plan year 2027. It allows us to take all the necessary steps, including an RFP for now. And it also removes the reserve limits for us to be able to transition with marketplace assessments in excess of operating expenses. So this is critical. This is a critical piece. We are not using general fund for this marketplace transition. Next slide, please. Here is the timeline of how things went down in June. It was a very busy June, of course, for our legislature. It is still pending to be signed by the governor. She does have, I believe, 30 days from signing day, so we are coming close to that. However, Senate Bill 972, the SBM transition, is a priority of the governor. So we are feeling pretty good about how things have happened throughout its sequence. Next slide, please. This is an information technology project, not surprisingly, and this will be led by the Office of Information Services. It is a central services division shared by both OHA and ODHS. So as of today, we met our project manager. She is fantastic. We have been assigned a project manager to oversee the technology portion of the project, which includes detailed project planning that ensures state IT oversight requirements, vendor procurement, and solution implementation. So as at this time, we have a senior project manager assigned, as well as a project advisor. Victor will be the marketplace business lead. He has accepted my request, and I will be the project sponsor. This core team, as of today, we are day 3 of planning. will most likely grow because there's a lot of facets to this project, and we will keep you all apprised as we go along. Next slide, please. For next steps, we will be putting together the business requirements for the RFP/vendor procurement. We will be making the necessary changes to our structure and staff to manage the new abilities and responsibilities that come with an SBM transition. Next slide. This timeline, I hope, is not new to many. This is the proposed overall timeline that we submitted as part of Senate Bill 972. This talks about what we're going to be doing high level from starting today through 2024, 25, 26, with again the goal of launching on or after November 1st, 2026 for 2027 open enrollment. Next slide, please. So we will be busy. Sorry, let me pause real quick. There's a helicopter making sure. Okay, great. So we will be busy the next couple of months. We already have started work. We are waiting for this month, which is down to the last couple of weeks. We are waiting for the governor's signature. We already have, as I mentioned earlier, an OIS project manager and project advisor, and we will begin the outlines of project initiation documents. In August, we will be gathering information from other states who have undergone SBM transition. Let me pause here real quick and just publicly express my appreciation for the Exchange Network. There have been a lot of states who have already transitioned away from healthcare.gov, and they are so very helpful. They are very, very excited for us. They are willing to share all their resources in terms of their project artifacts, plans, so on and so forth, and even are willing to meet with us to talk about lessons learned and anything that they can make our transition to be easier. They've already verbally shared that with me, and we will be definitely taking advantage of that help. In September, we are hoping to complete our baseline communications and engagement plan. Let me pause here real quick, because this is going to be where I believe the Health Insurance Marketplace Advisory Committee will be a critical partner. We hope to be able to provide you with something to look at within the next couple of months to provide your feedback. This will be part of the committee's work plan for 2024 and 25, 26, but short-term 2024, we will be building out this baseline to hopefully a more comprehensive version. It will most likely involve some work groups that you're all welcome to be a part of. So I don't have all the details yet, but I do know we will need your help and hope we can have your participation whenever you are available. Other things in September, we are hoping to complete artifacts for project initiation and hopefully also move to stage gate 2 deliverables. In October, we then hopefully will want to start reviewing the SBM transition CMS blueprint. This is the last piece is a little too, it's a little early for it to even us submit our CMS blueprint, but we would like to be able to plan ahead to see what needs to happen so that the SBM transition is not just an IT project. It will also be an organizational change project for us in the marketplace. So a lot of pieces will be up in the air. There's a lot of maneuvering that we will need to do and figure out. As you all know me by now, I like to have all my information up front so that I can plan ahead as far as possible. Let me pause there to see if I missed anything, because I know Victor is also here as our lead. Did I miss anything, Victor, at this time?
No.
Okay, great. Updates are skinny. Sunny Die only happened 3 to 4 weeks ago. We have a lot of information already planned because we have, we've been planning for this for a while. We've been proposing this for a while. We have business cases, we have content, we have help from other states. Let me pause there to see if anyone has questions for me at this time.
Tiki, I have a quick question regarding StageGate. Are those approvals through the legislature required to happen during session, or can they happen during the interim?
We can double check. This is Victor Garcia, I'm Operations Development Specialist for the Marketplace. We can check, but my understanding is that those can be approved in the interim. But I'm not 100%, so we can get back to you on that.
Any other questions for myself, Victor? Whether or not we have answers today, we can at least write that down and take it back and come back to you all with a response. Okay.
Good summary. Yeah, just maybe a comment based on this. Having maybe been the longest serving committee member, I can also attest to all the work that went into getting us to where we are. This is a really big deal for the state. And special shout out to Victor. He's put a lot of effort into it, among others, and also some of the former committee members who helped lead this to where we are today. And then just a call out to all of you on the committee now. I think now's the time, I think through you mentioned the engagement and the work ahead of us. I think there's a real opportunity for you all to help get us off on the right foot as we put this technology into place. So it's very good news to hear.
Thank you very much, Craig. And last note I would love to share with you all is CMS is aware of the passage of Senate Bill 972. They are very excited for us. They have been really good partners throughout the years that we've had to use healthcare.gov. We've done what we can, and they recognize that Oregon wants to do more and do better, and they would like to support us. So at some point, they will assign a transition officer, is what I believe they call him, and we will share updates about that process as well. So this is all to say thank you and apologies in advance. We will be throwing a whole bunch of information at you for the next year or so and looking forward to the partnership. But I also think I just saw Drew's hand go up. Drew Tarab?
Thank you, Chiki. Wicked excited for this. All the same enthusiasm you have. In addition to seeking, I guess, stakeholder feedback in the HIMAC forum, will there be other forums to have stakeholder input?
Yes.
Great.
Yes, there will be
information on that, or more wait and it'll be coming out.
I'm sorry, can you broke up a little bit for me? Can you repeat your last question?
Do you have more information to share about other stakeholder forums, or should we just wait and that'll come out later, like September, October time?
So the hope is to provide you with a baseline plan in September, including a list of potential audience engagement opportunities. So that will include tribal consultation, community partners, insurance agents, even consumers. This is a big deal for all of us, and also for the community. And we hope to really engage the community as much as possible. So that, at least I can give you my commitment that there will be more, and it will just not be reserved for the HIMAC. So HIMAC will have its opportunity, and we'll also definitely have other opportunities for the different audiences that we will be working with.
Thank you.
Yes, and Victor has additional information for us.
Just wanted to add that would be all of the formal stuff we would always want to do before getting a product from a vendor, like through an RFP. But in addition to that, we'll have mechanisms for just having ongoing dialogues about these things, because once we have the system in place, that's not like it. You know, we're all done now. There will be evolving things, issues that continue to come up, and we will have to continue to have this engagement so that we can then, now that we have the ability to make the changes to the marketplace platform or our policies to accommodate whatever we need to. So it's having that ability that's really the main reason we're doing this. So again, just to say, whatever we do at the beginning, we'll just continue to do, because there will be no end to that engagement.
And lastly, I keep saying lastly, I keep thinking of things that I want to share with you all. We will be working very, very closely with our partners, the rest of our partners, our family team members with the One System. This is going to be critical for us to really make sure that we connect very well with the One System, connect, communicate, streamline our work processes. There's a lot of work that we need to do, and we want to make sure that they are part of this project day one. They may not be the core members, but they will definitely be part of the team. So please know that Medicaid, OHP, they will be part of the Marketplace SBM transition project, because we need them. We need them, and we want them to be part of everything from day one. I don't see any other questions. Please do feel free as you think about them. Please don't wait until the next HIMAC meeting. If you think about it, write it down, email me right away or email Victor. We will make sure, even if it's late at night, we will make sure to log everything so that we can hopefully address your questions, your concerns, your suggestions as we go through this project.
Great, thanks, Chicky. So next we will move on to hear more about the unwinding of continuous eligibility. And we have Vivian who's going to talk to us about that.
Hi, everyone. Thank you all for having me back. Appreciate the chance to give you an update on where things are, because time seems to just move faster and faster, and we have gotten through 4 months of initiating renewals, and so have some new information to share with you. We can go to the first slide. Actually, the next one. So the first thing I want to talk to you about are the dashboard, the public facing dashboards that are available with a bunch of information and are getting updated with more information focused on a couple of different things around the unwinding. There is, and I'll show you this in just a minute, there's a section that's focused on individuals who are going through their redeterminations and really diving into more detail about who those people are and giving us an opportunity to start looking at that data and analyzing it. And it also has information about operations and the ODHS eligibility operations and sort of where they are in terms of call center metrics and documents that need to be processed and worked through. So if we could go to the next slide. So in terms of some of the updates that have been made in the last several months to these public facing dashboards, we are adding more and more information about the outcomes that happen to individuals now that we're starting to see some outcomes, and whether that's benefit reduction, whether that's closure, whether that's finding people eligible, and displaying more of a breakdown of who those people are. What CCOs are they or were they in? Were they fee for service? What are their Real D characteristics and demographic breakdowns? And really being able to use this data as a tool for learning. As I said, this also talks about whether a case is waiting for action and whether that action needs to take place by the state or whether it needs to take place from the member. Next slide, please. So the next update that's going to happen is going to include the total workload. And that's really important because, of course, we know that we have an integrated eligibility system. And that integrated eligibility system includes SNAP and TANF and employment-related daycare. And so since we have one workforce who is processing the eligibility in the one system for all those programs, it's really important for us to be able to have and give others a clear view of what that total workload is and how it is fluctuating. Next slide, please. So this is what the medical redeterminations dashboard looks like now. For those of you who are familiar with it, there's some extra buttons and some extra information here, but if we can go to the next slide. So this is some of the information that is available to you now that I can just show you in a little bit more detail. This is the customer service dashboard, of course. So this shows average wait times, abandoned calls, accepted calls. And it also shows here at the bottom the statistics from the customer service survey that randomly comes up after somebody has an interaction with the OHP customer service folks. And you can break this down by our eligibility staff, our support staff, as well as our special applicant portal team that answers questions from people, from members or from community partners who are applying through applicant portal. Next slide, please. This is the dashboard that gives you kind of a high level look at where people are in the process. So you can see that we have completed 470,000 renewals, although I'll talk in a minute about why that why it's not quite that simple. And we have about 900,000 that have not yet started. So when I say it's not quite that simple, and I'm going to give you some more detailed data about this in a minute, but that completed number right now includes people who have been found eligible at renewal, but have something that they need to do still. Some verification that they need to provide, whether that's for income or other things, most frequently for income. And if they don't provide that verification, there's a risk that they could lose coverage. And so we are working with ODHS to break that out so that there's some more accurate data there to reflect the people who actually have completed the process and have nothing else that they need to do, and they have a new eligibility period, versus the people who appear eligible but do have to do something in order to remain eligible. I want to stop for a minute before I go into the more detailed stuff and just see if anybody has any. I'll take questions at the end, of course, too, but I'm throwing a lot at you. So I just want to see if anybody has any questions yet that they want to ask. Okay, cool. We'll keep going. So this next slide shows you what the detailed level of the dashboard looks like. This is the information that was added in June, breakdown of language, gender identity, race, ethnicity, disability status, housing status, as well as a map that you can click on to see the distribution of people throughout the state, and get a sense of where people have been renewed so far and where they have not. One caution that I want to give around around all of these numbers, but specifically around the housing status number, is that obviously data is only ever as good as the questions that you ask to obtain that data. And we don't have a question on our application right now that says, are you unhoused or at risk of losing housing, or some other version of that question. What we have and what we use to derive this number is a question that asks people if they have basically a stable residential address, a permanent residential address. And if they don't, there's different information that they can give us. And then we also ask a question in our living arrangement section around whether or not people are in a homeless shelter. But obviously that's a small percentage of people who are unhoused. And so I just wanted to call out the deficiencies with that number. I expect that number is actually quite a bit higher than what is reflected on this dashboard right now. Next slide, please. All right, so here's where I get to give you some real detailed numbers about where we are. So as I said, 450,000 people have come up for renewal so far. So that means we've initiated the renewal process for those folks over the last 4 months, and they are at some stage of the renewal process. And that is almost 30% of the total OHP population. So of that, 64.3% of people have been found eligible at renewal, and there's nothing they have to do. They did not receive a request for a verification. They are good to go. We have everything validated, and they have a new eligibility period. About 22% of these total individuals received an RFI, which is a request for information, something like verification for income, for example. So those are people where either they may have responded and we have not processed their response yet, or they may not have responded yet. And because the renewal process has many different opportunities for people to respond before they actually lose their benefits, we're not going to have really accurate information about how many people lost benefits due to non-response until the fall, until like October. So I just want to kind of set expectations about that. There's going to be some ebb and flow here where people move into different categories. But this helps to give a really good picture of where we are right now. People who are sent a full renewal packet, what we call an active renewal, and that just means that they get the packet and we ask them to review it and sign and return it, or they can go onto applicant portal and sign and submit their saying, you know, either there are changes or there are not changes on applicant portal. So about 8.5% of the total number of people we've renewed have been sent one of those that they need to return. And then in terms of benefits ending, that's about 24,000 people have actually had their benefits end. And at this point, that would be because they have been found ineligible based on the information that's on their case. So again, this is just the picture from April to June. And so next time I come, I will bring another update. And the further we get into the process, the more clarity we'll have about outcomes. But we are doing everything that we can think of, sending reminder notices, having CCOs do direct follow-up, having community partners do direct follow-up, to make sure that we get as many responses as possible from folks. Next slide, please. So the first losses of coverage happened on June 30th. And though that was really the people that I mentioned before, the around 8,000 people who were not eligible anymore based on the information that we had about them. And those are the folks that received their closure notice in April when we first initiated the renewal process. So this is just some information as you are out there as community members, providers, family members, when people do lose coverage. First of all, first thing, if someone feels like they should not have lost coverage, is to remind them to review their case summary, which everyone will everyone will receive a case summary, including people who have been found ineligible, and make sure that that accurately reflects their situation right now, including their income. And if it doesn't, then they should contact OHP as soon as possible to let us know that so that they can be restored. So that's number one. Number two, obviously there are other options that people have available, and sometimes if they have been on OHP, they might not be aware of those options, or they might think that those options are not available to them now. For example, with employer coverage, a lot of times people think they have to wait until a certain enrollment period, and they don't understand that if they've lost their OHP coverage, they may have access to a special enrollment right for that coverage. Same type of thing with Medicare, letting people know that at any point along the way, if they've lost their OHP and they're eligible for Medicare, they should start that process right away. And there are people and organizations like Sheba out there to help them through that process. Not assuming that health coverage is too expensive. People are often very surprised with the amount of financial help that they can get through the marketplace. You all know that very well. And so just helping to sort of dispel that rumor that there's no way I'm going to be able to find a plan that I can afford, and trying to encourage people to go through the process and find out what they're eligible for, and that they might be able to get the coverage that they need that way. And at the bottom here, there's just some additional resources to help connect folks to community partners and insurance agents who can help them through the process. Next slide, please. So last but not least, we very much want your feedback. I think I said this last time I was here, and it is as true as it ever was, especially right now as we are going through this period. You know, at the end of July, we're going to be sending a large number of closure notices to folks who did not respond to requests for verification from April. And we want to make sure that if there are issues that come up, that we have eyes and ears out in the community who can help let us know what's happening. And so we do have this feedback email address at the bottom here. And we also have a feedback web form that you can fill out. And again, I want you to know that there are real humans on the other end of that. That is not just an automated email that goes into a black hole. There is a wonderful team, actually a lot of folks from the COVID response team who have come to work to do this work for us. And who are really actively working through questions, concerns, and issues that come up there to make sure that they get resolved. So please do not hesitate to reach out to us. Next slide. All right, that's it. Does anybody have any questions?
Yes,
Thank you. Hi, Vivian. I'm a little bit confused, maybe just because I just traveled overseas and still dealing with jet lag. So we are do unwinding, but we also effective on July 1st this year, the Healthier Oregon get all the immigrants to be on Oregon Health Plan. So it looks like we are trying to get people out from Oregon Health Plan, but then we put a new group in. Can you help me understand that better?
Yeah, absolutely. So this is a factor of a number of different things happening at once, which they seem to always be. Last year, as you know, Healthier Oregon was passed by the legislature, but it was only partially expanded to a couple of age groups. And the way that the legislation was set up, the intention was always for it to fully expand to all of the available or all of the eligible individuals, excuse me, on July 1st. We had no idea at that time, believe it or not, when the unwinding would happen and when we would be going through the post-public health emergency redetermination. So these things happen to be colliding and happening at the same time. What we are doing to try to mitigate some of the confusion for our new Healthier Oregon members who have just found out that they are eligible for Healthier Oregon is that we took the redetermination dates wherever we could for those folks and pushed them out of this month and next month so that they would at least not be getting a renewal packet and a congratulations, now you have OHP plus letter at the same time. There is also outreach that has begun. Unfortunately, it couldn't begin until very recently because we had to get confirmation with our budget that the Healthier Oregon expansion was going to move forward, but it has started now to reach out to everyone who has become eligible for Healthier Oregon and help to the greatest extent that we can sort of explain, you got this letter, just to prepare you, you're going to get another letter that lets you know you're going through the redetermination process, and here's what to do when you get that letter. So two separate changes, but they are happening at the same time and they're happening to some of the same people, and we're trying to manage that as best we can.
Thank you. Thank you.
Of course.
Yeah, thank you. Are there any other questions for Vivian? Vivian, I have one question for you. Can't help myself. Dawn, can you go back a couple slides? I just want to make sure to the ones with that one, the circles on it. So this is really helpful. And by the way, just generally, Vivian, I know a lot of people that I work with use the dashboards that you present. So thank you for making those available. But this one's a little bit different. So I just want to make sure I'm following this. So I think the top circle makes sense. They're just done. And the bottom one, benefits ending, makes sense. But the two middle circles, the individuals with an request for information, I think that one, and then people send a full renewal packet.
It doesn't, the percentages don't make sense.
Well, maybe they, actually, I didn't even do that, but I'm just thinking, oh, right. Yeah, I didn't notice that. I just was curious about, we don't know whether they'll retain coverage or not. Is that right?
That is right. I have to admit to you, as I was presenting this, I was looking at it and thinking, how can 33,000 be 21% and be 8%? That doesn't seem right. So I'm going to go back and figure out what is going on with those percentages. But yes, you are absolutely right. These two numbers, this approximately 67,000 people, represent the people who we don't know yet whether or not they are going to respond. And if they don't respond, they will lose coverage. And if they do respond, then we will review their response. And it is likely that they will remain eligible, but not guaranteed, depending on the information that they submit. And so that's really the population to focus on as we go through these next several months, to see how many of those folks do end up responding and how many of them do we retain on OHP.
Okay. Great, thank you.
Of course.
Any other questions for Vivian before we move on? Okay, it doesn't look like it. So I think last on our formal agenda, we have Nina Rempel, and she's here in person to talk to us about the Marketplace transition project updates.
Thank you, Greg. Okay, so again, with the transition project, where we have a call center set up ready to help anyone that gives us a call. We are starting to see more calls coming in now that the first cancellation termination date of June 30th has come and gone. And now that the RFI, people that have received the RFI, their 90 days is coming to an end July 31. And so they'll then get cancellation notices if they haven't taken any action. We've also gotten more, we've actually started getting our 30-day file that we were expecting from CMS with regards to folks that now 45 days after their initial termination have not yet enrolled into a QHP. We sent out 6,300 text messages to these folks, and that is also showing an increase in calls to the call center. So we're pleased to see that. From the 30-day file, PH Tech is making outbound calls to offer assistance. We make 3 attempts to give folks a call to try to reach someone. And so we're seeing about 18% that we're able to reach and either provide more information or just make note of any changes to their situation with coverage. Let's see here. So here are the projections so far. This is on our dashboard, and you'll see that we've sent out about 24,000 letters in the various different languages. We, again, are seeing from the return mail, we also, again, try to do the outreach with phone calls if we don't have a new address to send the notice to. So our help center is staying busy with the information that we have going back and forth to folks. Next slide. So our grants, we now have 6 community-based organizations in the process of getting their grant agreements executed. These are the communities of focus. The 2 newest organizations that we're bringing on are Ethiopian and Eritrean Cultural Resource Center, as well as Mercy Connections. And so we're very excited to have them be able to do the outreach to their communities of focus. We have already been invited to some of our grantees to give presentations on basic health information, basic health insurance information, as well as help support some of the events that they are hosting or tabling at. So we're very excited to continue to make sure that the grantees have the information to share with their communities to get people into coverage in the marketplace if necessary. Next slide. And again, how to help people losing their OHP benefits. We have a link here to participating facilities for not-for-profit hospitals that may offer, have assistance programs available, as well as using the window shopping tool with the marketplace. So again, you can help folks get local help using our Get Help tool through the marketplace, and the links are here. Our agents and community partners are very, anxious and excited to help people come their way. We haven't seen much of an influx yet, but hopefully that'll get us there, especially moving towards open enrollment. Are there any questions? Thank you.
So here in this section is, we would love to hear from you all if you've heard from the community about how Medicaid redeterminations has been going, especially if they've needed to transition to a marketplace plan. So generally that's the question. And if you've heard of any, we would love to hear from you. And if you can say it's been going perfectly, we will take that too. Gladys?
Hi, Gladys Boutwell, insurance broker. So on one of the slides, going back, when it comes to the call center or those that are getting the calls, they're sending them to healthcare.gov. Why wouldn't they send them to the Oregon State to say, hey, this is where you can get help, local help? So that way the person can either do it via phone, via Zoom, in person, and they'll be connected to a local broker that's actually going to help them choose a plan that's specific to them versus calling healthcare.gov or having them do it online. Or am I missing something on that piece of it?
That slide is actually pointing to OregonHealthcare.gov, which is the common kind of screening website that we use, and that does direct people to the local network of community partners and insurance brokers.
Perfect. All right, perfect. Thank you much.
Of course.
Thank you, Vivian.
And then Holly, I believe you also had your virtual hand up.
Thank you. Yeah, Holly Sorensen here. Just a quick couple comments in regards to how we've been experiencing Medicaid redetermination thus far. It seems like one of the initial first populations or groups that's kind of experiencing the first round of redetermination seems to be those over 65 or with disabilities that have non-MAGI Medicaid programs. And so we've been making a lot of referrals to our local agent partners that specialize in the Medicare programs and just kind of helping them follow through on the steps that the one system prompts, whether it's completing an asset verification interview. And so, you know, it's just a little bit, I think kind of one of the harder groups to kind of assist as far as like our expertise and like our scope as assisters getting into the Medicare side of things. But that's why we are friends with our local agents. So that's kind of been our focus so far. So.
Thank you, Holly. Nishoba?
Hey everybody, Nishoba Temperley. So we've been facilitating quite a few of these at my organization, Cascade AIDS Project. While we've had a few successful actual transitions, which I'm proud of, we've just faced a lot of hesitancy and confusion, as we've expected. Folks that have kind of not followed up with some of our outreach, and particularly those that are kind of skeptical of cost sharing and financial assistance, affordability, which is forever the case. I think one thing that I would highlight for the group, just as a perspective, individuals like that we've kind of talked and kind of isolated are self-employed individuals, right, on OHP that have gotten requests for information, have been pretty confused by some of the language and processes to submit proof for that RFI for income, tax statements, and future estimations, lack of forms. So there's been quite a bit of confusion in some of those letters, but you know, we're doing what we can to mitigate those things. But we've had some success, but it's really ramping up for community partners out there on the ground. That's for sure.
That's really helpful feedback. I appreciate that. I will make sure to take that back to the team and see if we can't take a look at some of that language and do what we can to provide some more helpful examples, or you know, make that language a little clearer. And if you have any suggestions, any of you, anything specific from working with folks who get those RFIs, I would love and appreciate your feedback and input. You can send it to that feedback email, or you're always welcome to email me directly.
Thank you, Vivian. Sorry, I pressed the wrong unmute button. I pressed my computer, so my apology. To piggyback off of Vivian's request, as we all know, Medicare open enrollment is around the corner, October 7th, if I'm remembering it correctly. Marketplace open enrollment is November 1st. We are heading into that period where there's a lot of messages about enrolling into a health insurance plan, whether it's, hey, sign up, you know, submit documents for your RFI to keep your OHP, or transition to a marketplace plan or a Medicare plan. We would love to hear any suggestions for how we can help lessen the confusion. Like we hear, right, that there's already confusion happening now. And then as we enter into this peak season, what else can we do? What else can we do, or what can we do differently? So if you have thoughts you can share now, or would love to share at a later time, would love to hear it, please.
Looks like Holly has a question.
Thank you. Not so much a question, but just an example of something that we've seen that's confused folks in these OHP RFI notices have been specific language pointing them to, we shared some of this information with you in another notice, so go find that notice for that information. So they're kind of like, I got this one, but I don't know if I got the other one. So we're able to go through that because we have access to their correspondence. But I think that's the biggest example so far of the confusion in notices. It's like a scavenger hunt of find the other letter.
The scavenger hunt, except it's no fun at all. Thank you for sharing that. That is something that we have been talking about, because when people right now, when somebody needs to provide verification, but they appear eligible, they get one notice that says, great news, you're eligible. And then they get another notice that says, oh, but also you have to provide us this verification by the state or you won't be eligible anymore. And so we are having some conversations about, can we switch the order or can we combine them or that kind of thing. But that specific feedback is really helpful. Thank you for that.
A question, maybe Vivian, you can help shed some light here. Yesterday, our marketplace call center, not the help center with the transition project, but the marketplace call center, got a couple of calls from people that said they got a cancellation, OHP cancellation notice. And so they took that information, they went to the marketplace and enrolled in a QHP. And then they got another letter that said, oh, you actually are still eligible and you have coverage for the next year, for another year. So then they were confused. Now what do I do? So of course we ask that they call the OHP line to verify that they actually had eligible coverage before they cancel their marketplace plan. So is this because of the expanded coverage now that they're, for anyone 6 and older getting 24 months?
No,
it just seemed odd that 2 calls came
that
in.
should not be happening. Nina, if you have any specific examples that you could send over my way so we can take a look at the case, I would really appreciate it. Because no, there's not. That sounds incredibly confusing, and there's not any reason why it should be happening that way. If it's 1 or 2 off because perhaps staff made a mistake and then corrected that mistake, I would like to understand that, but I'd also really like to understand if there's some larger issue going on. So.
Okay, thank you. I'll see if I can get any details on that.
Thank you.
Do you have a comment?
It's just a question, following that, I got a phone call, my office got a phone call that a member on Marketplace received a letter that eligible for OHP, but a family of 5, 4 of them got OHP, but not a husband. Is that possible?
The only way that should, the only way that should really be possible is if there is some unusual tax filing situation where the husband files taxes separately and doesn't claim any of the kids as dependents. That's the only valid situation where I could think of that would happen. Otherwise, if that's not the case, I think it's likely a mistake and I would contact the call center about it.
I do have another question. How do you take care of the unhoused people for OHP?
So a number of different things that we are trying to do. First and foremost, we have an incredible group, an incredible network of community partners who work directly with folks who are unhoused in all sorts of different situations or even at risk of becoming unhoused. And so first and foremost, trying to work with them and empower them to be able to get the message out, to be sure that the people that they work with understand that there are, that we do need to be able to get information to them, but there are all sorts of ways that they can receive mail or that they can get information from us electronically so they don't have to be dependent on the mail. And we also have a kind of marketing public education campaign that started just a couple of months ago. If you've seen any of those funny little jelly bean people on your TV or on billboards saying, stay covered, here's what you need to do. Besides those sort of more generic ads, there are a lot of, there are, I think, 12 different targeted campaigns that firm is helping us work through and ensure get out there. And one of those campaigns is targeted to individuals who are unhoused, to make sure that we're taking extra steps to get them the information, and help them know what they need to do. So those are some examples, but I will not pretend that it's not a challenge. And it's certainly not a challenge that we have figured out perfectly how to deal with. We are always trying to get better in that regard. So those are a couple of the steps that we're taking.
Thank you, Vivian. That was a lot of feedback, so thank you all for jumping in. Appreciate you also, Vivian, for hanging on. I know you're very, very busy to help address some of our questions and feedback. This is not, Vivian is always very gracious when we say, hey, can you come back to the HIMAC and talk to us and give us updates? So thank you again for sharing some of your time. We know you're always triple booked, so thank you so much, Vivian. I'm sure we will ask you again in October if you don't mind.
Of course, happy to be here and happy to come back. Thank you all for your feedback. It's very valuable. Appreciate the work you do.
Before you go away, Vivian, I was just thinking, since we don't meet till October, there may be things that come up within the next few months. As this continues, are you open to receiving feedback via email or virtually?
Absolutely.
Okay.
I would love that, genuinely.
Great.
So yes, again, to the feedback email or directly to me, either one is fine. I think there's really few things that are more valuable than feedback from people who are working directly with the people that we serve. So
yeah, that was a great discussion, and I appreciate the committee members for their comments and observations for sure. And also just to see how well the OHA and the marketplace are trying to coordinate this very complicated situation. So thank you. With that, I think that brings us to the end of our formal agenda. And we will have one more minute for public comment, and then Chicky's going to let us know about some things to expect. So why don't we open things up for public comment at this point? Annie, before we close, I think Chicky wanted to let us know what to expect for our next meeting.
Yes, so thank you everybody again for your time today. Our next meeting is October 12th. It is from 9 a.m. to 12 noon. It will be another hybrid option. If you would like to come to Salem, we would love to see you in person, but we'll also provide you with virtual means. Our October meeting already as identified in the baseline work plan, we will have open enrollment updates because as we all know, I keep saying this, November 1st is our open enrollment time. We will also be covering marketplace transition project updates, as well as get another update about Medicaid redeterminations from Vivian. So Vivian and Nina will be back. So I'm already looking at Nina. I'm like, Nina, you will be back, please. We will also be talking about basic health program updates and marketplace mitigation impacts, updates to those. So we will also invite Tim, Laurel, Nikki, as well as Katie Button back. And because it is October, we will also be inviting back Tasha Sizemore and or another representative from DFR, as well as our plan management analyst, Katie Button, to talk about what to expect for open enrollment in terms of plans. What is not in your baseline work plan, but now we will add is, of course, SBM transition project updates. So that will also make your way in October. Because we all know you are very, very busy people, we will be also working on the 2024 meeting calendar, and we will send that your way in the fall, as well as meeting invites. And then, of course, we now also need to update our work plan. We have a 23-24 baseline work plan that has been guiding our agenda, as well as discussions, offline meetings as well. We will be working on that and sending it your way for review prior to the October meeting. So we are hoping that we can get the committee's review before that so that we can hopefully vote on it in October. So lots of things happening the next couple of months. The team is, of course, working on getting ready for open enrollment. We, as a quick update, we have already started our training for our community partners. That started July 1st. That will be ongoing throughout open enrollment, and that's available in person as well as webinars and on demand and available in English and Spanish. So that's already, we are already working hard on that. Plan management is already happening, making sure we have quality plans available for Oregonians to purchase starting November 1st. Those, I'm sure I'm missing a lot of, there's a lot of work happening, a lot of projects happening for the marketplace team. If there's anything that you feel like we didn't provide you updates about, please do let me know and we will make sure to send them your way. I think that's plenty for wrap up for me, but please do let me know if I missed any critical details in there.
Thank you. A lot to look forward to in October. All right, before we close, just wanted to open it up one last time to committee members if there's anything that you'd like to add to the meeting today. Okay, not hearing anything. Just want to thank everyone for their participation in our committee meeting and for the presentations as well. So thank you all, and we will close and see you all in October. Thank you.